It's working. There we go. I feel like this is where we stopped, however many days ago. Does this seem right? So up until now, we've kind of been saying general things about the way that antimicrobial drugs work and had been focused on the penicillin group or the penicillin class of drugs. And I was using those as a specific example of one class of drugs and how they act. So just to kind of review that. The penicillin class of drugs targets peptidoglycan synthesis. And any of this related group of drugs in the penicillin family, they all have this beta-lactam ring structure. And as a group, they're going to prevent microbes from building new peptidoglycan. So because that's how they act, penicillin class of drugs is going to be effective against bacteria specifically. And there are other classes of drugs that are also effective against bacteria, but we're kind of turning now to look at what about making drugs against non-bacterial infections. So if we think about, okay, what are the groups of organisms that infect people? You've got bacteria, but also fungus and virus and helminths. And the non-bacterial microbes, it's way more difficult to develop drugs against those infections. And the drugs that we can develop tend to have worse side effects. Why are these so hard to develop drugs against? Because they are what?
Harmful to us.
The drugs that we develop against these are going to be harmful to us too. Because this group are going to have several shared targets. Similar to what our cells already have. So if you're a virus, you're using most of our machinery to operate your life cycle. And if you're a helminth, you're an animal and we're an animal. So it's hard to come up with some drug target that is specific to them. It's not also going to harm us. So these two are eukaryotes, just like us. Virus is using our machinery anyway, so drugs out of these classes tend to have worse side effects and in some ways not be as effective as antibacterial medicines. So what's coming up in these next few slides is just to kind of say, what are some antifungal drugs and what do they tend to do? What do their targets tend to be? And then similar for worms and viruses. So for fungi, one of their best targets that we don't have is a particular part of their cell wall. So this is showing what's the cell wall structure of a fungus and showing, okay, what if you disrupt this part? That's this name of drug. What if you disrupt this, and so on? So what I wanted to do with this is kind of highlight some major drug categories. The ones that I feel like you're gonna see the most often. So the first is a category called imidazole. Imidazoles. And what imidazoles actually do is to block the synthesis or the building of some cell membrane stabilizers. And in a fungus, those cell membrane stabilizers are these blue things here, and they're called ergosterols. So fungi use ergosterol to help stabilize their membranes, but humans use something related. Instead of ergosterol, we use cholesterol instead. So they're related in structure, but not exactly the same. And then the second one that I want to highlight up here is flucytosine. This one is useful against fungi and also viruses. That one has a pretty broad action. So flucytosine class of drugs will block an organism from making new DNA or new RNA. And the way that this can be effective to use in people is that we don't have to generate, let's say, like, I've got a fungal infection and I'm going to take flucytosine for a couple weeks, and I'm going to be okay not making DNA and RNA for a 2-week time frame. Like, it's not great, but it's not going to damage me that much. But if you're a small organism that needs to be dividing and you have a short life cycle and you can't make DNA or RNA for 2 weeks, that's going to kill you. So you have to take advantage of slight differences, target what you can with these drugs, and hope that they don't cause really bad side effects in the person. There's other categories of drugs that are useful against fungi also, but those are the two I wanted to highlight today. And before I erase this, flucytosine can also work against viruses. It has multiple types of pathogens that it targets. So a couple of other drugs that are useful for viruses have a similar type of action, and they can be called acyclovir or amantadine. And these also inhibit the nucleic acid processes. So they're going to disrupt forming DNA or RNA. And again, as humans, we're going to be okay for a while without making new DNA. But if you stop that completely, a virus cannot continue its life cycle if it can't make DNA, RNA quickly. So they are going to have side effects, but it's effective to stop a virus in the short term because their life cycle is so much shorter than ours. They don't need DNA and RNA, or they do need DNA and RNA frequently to build those. These would have been tried for COVID treatments and they work kind of. Some, they work some. Okay, so for anti-protozoan drugs, I don't have specific examples that I want you to know of what they are called, except for one. So if a drug has the term quin in it, like Quin, like quinine is a really old one, that was developed as an anti-malaria drug. Or quinolones, or something quin, like that. Those tend to be anti-protozoans drugs. And as a group, they tend to inhibit the movement. Inhibit the movement processes. Of protozoans. So they depend on swimming for their life processes. And if you can block them from swimming, that can be a helpful way to reduce infection. This one, you know, it says naphthoquinone inhibits mitochondria, and then that would reduce ATP that's available for protozoans to swim. And then for helminths, they're worms, they're animals like us. Probably have the most shared targets. So a couple of major anti-worm types of medications are benzimidazoles and one's called avermectin. And one that's made the news a lot lately is called ivermectin. So ivermectin tends to be used for animal deworming. So when I was growing up, we actually kept a decent sized carton of ivermectin in our house fridge because we raised feeder calves. And we could use it to deworm them. And then if you made a lower dose, you could also use it on dogs, which we also had. Where this has come up in the news is to be in people COVID medication. And it's kind of been controversial, like, should we give this to people? Does this work in people? Is this going to help them recover from COVID? And the answer to that is interesting in why it works in some people and not others. So this is what has turned out to be the case. It took a while to figure out what was going on with people and COVID and ivermectin. So what happened with ivermectin and COVID was there had been studies, well, like real preliminary early studies of if you gave this to people with early COVID infection in the countries where people were more used to using ivermectin. So say Southeast Asia and Africa, it's much more common for people to take ivermectin because they tend to have worm infections. So in those populations, people that took ivermectin did have a pretty good outcome with reducing COVID symptoms and having lower death rates in populations. Because if you treat their worm infection, it improves their overall health enough and improves their overall energy supply enough that their own immune system is better able to fight off COVID. So like by improving the person's whole health and getting rid of their worms, they also became more COVID, more resilient to COVID, let's say. And there were some fairly good results there. In populations of people that used ivermectin, like in the US and Europe and the more advanced countries where they tend to not have worm infections, it didn't do much to help. And it took a while to figure that out, but ivermectin, which is an avermectin class of drug, it has been in the news a lot because of people thinking, should we be using this more as a COVID medication? Well, it depends. If you don't have worms, it's not going to help much. If you do have worms, it's worth using. And I think these also end up affecting the worms' movement in various ways. So affecting the worms' internal energy supply, and they can't move as well, or they can't grip on as well to your intestine. That's how they work. So what I want to skip a few slides and go to something toward the end of the slide set because it involves doing math. And I thought, okay, if we do this early, you've got more time to practice it before the final. And then we'll come back to drug resistance later. So we're going to skip to this. Okay, so we're going to skip to drug selection. How do we pick out the best drug to treat a person? So imagine you've got a patient in the clinic, and they have an infection of some type. What type of things do you need to know to figure out what drug to give them? Yeah. Oops. That's off. So you want to find out what are their signs and symptoms. Are they allergic to any drugs?
Probably one of the lot was open.
Yeah. Keep it coming. What else? What else would you ask somebody? That's to prevent drug interactions. Sometimes drugs block each other's action or cause combination effects together.
Symptoms.
I'll call it the problem. When did the problem start? This basically becomes a list of what you're charting on a patient when they first come in. So all those things that the doctor or the nurse practitioner, the physician assistant asks you goes into this, including your weight, your age, and then under past medical history, that would include your pre-existing conditions, etc. Okay, so those are part of it. What about on the the pharmacy end? What is the pharmacist going to be looking at when they see your prescription? This may not have happened to you all yet. You ever gone in and they're like, this one's really expensive, so we're going to call the doctor and see if they'll accept a generic. Ever had that happen? So the cost is sometimes an issue. Maybe were you going to say something?
Well, they can look at it, whatever the medication they called in and tell what type of infection you have, depending on what they call in, so.
Usually, yeah. Yeah. So these two have something in common, that these are telling you what the infection might be. So by asking the signs and symptoms, when did it start? This is trying to get at what is the infectious agent? Or let's say, what is the infectious microbe? What actually is the infection? And sometimes that's not exactly known until later. So here's an example that's happened to me. Thank goodness I don't tend to get UTIs. I've had one that I knew of, but it was a really bad one. So go into the clinic, pee in a cup. Apparently I'm peeing blood. I wasn't aware. Fine, I have a bad UTI. And they said, we're going to prescribe you. So this is, 10 minutes later, 15 minutes later at the urgent care. We're going to prescribe you this drug. Start taking it. It's probably helpful. But they said, keep an eye on your phone. And if we find that you've got a different infection, that this drug won't help, we'll call you back. And they did. So they took my urine sample back. They actually tested what I had, which takes 24 hours, 36 hours. And then they found, oh, that drug that we gave you, that's actually not going to do anything. Here's a new prescription. That didn't used to happen. It used to be, here's a drug, take this. Call us in 5 days if you don't feel better. So identifying what is the infectious microbe, this takes time to actually do. And sometimes the medical professional will consider that it's not worth waiting that extra number of hours before they prescribe something. But the best would be, oh, you actually figure out actually what you have and prescribe that specific drug that you're sure is going to help. So all of these things have to be considered, and it's kind of complicated. And something else that needs to be considered is what is going to be the dosage and what is going to be the route of administration. What's route of administration?
How you get it.
Is it a pill? Is it IV? Is it a suppository? We don't use those that much in this country, but what is the form? What is the form of the drug that's going to be given? All of those go into choosing drugs. If you become nurse practitioner, physician assistant, you gain more responsibility to actually help choose drugs. RN nurses do not choose drugs, but it's still worth knowing some about how drugs are chosen. So those are the things to consider. If a person is allergic to a drug and they know that they are, then you definitely would not prescribe that. When they are allergic to a drug, it tends to present as a type 3 hypersensitivity, which is serum sickness. So serum sickness is when you have the drug circulating all over your body and it causes reaction in tissues all over your body, and it tends to present as this kind of rash that's everywhere. There will always be a few patients that are allergic to a drug and they don't know it yet. So when you counsel them about, okay, here's the drug, we're going to give it to you, and you tell them, please notify us if you have any reaction. There will be some number that will have a reaction. They don't know yet that they're allergic to that drug, but it tends to present as an all over skin rash. Part of prescribing drug will also have to do with, okay, what's the dosage and how often do you have to take it? That's what we call dose frequency. What's the most, if you've been prescribed pills for something, what's the most times a day that you have to take it? I think 4 for me is the most. I struggle with remembering to take pills once a day. So the fewer times that the people have to take the drug per day, the better, because they will tend to follow that better. But how often you take a drug depends on the half-life. So half-life. That has to do with, okay, how long does it take for the concentration of drug to become half of what it started out as? So if it has a short half-life, that means it breaks down quickly. It's kind of like a radioactivity concept. So the half-life of the drug depends on several things. First, how is it administered? Like, did you get it through an IV? So the concentration peaks really fast and then it declines at a medium rate. If you take the drug in a pill form, it takes it a while to get, to get into your bloodstream because it has to cross through your stomach and be absorbed. Then it'll reach medium concentration and decline at a medium rate. Intramuscular, if you get a shot into muscle, it's kind of in between those two situations. So it depends on how is it administered. How fast is the drug processed? In the liver. So some drugs, when they pass through the blood supply of the liver, they get converted into active form. So liver function affects this. And the third thing is how fast does that drug get broken down or excreted in the urine. So depending on the chemical size of the drug, every time it passes through your kidneys, you'll get rid of some of it. You will pee it out, basically. So all of that goes into, okay, how often do the people have to take it? Is it slow release? Is it once a day? Is it once every 3 months? My mom takes some kind of bone building medications, like once every 3 months. It's great. So this concept of what drug is actually going to kill the microbe causing the infection, this is what we're doing in lab tomorrow. Something called antimicrobial sensitivity testing. And this answers the question, will a drug actually treat the infection? Will the drug actually stop the microbe that's causing the problem? And to know this, you really need to get a sample. So get a patient sample. Might be urine, might be blood. Get a patient sample. Then isolate the microbe causing the infection. That's step 2. And then step 3, you would want to test that microbe against specific antimicrobial drugs. And determine actually what drug is going to be effective against this microbe. Because sometimes you don't know, it might be resistant to the usual drugs that you normally would use. So in step 3, that's what this type of experiment is that we're setting up in lab tomorrow. So this experiment, you're going to take a pure culture of the microbe that you get from step 2, and you're going to streak it all over this big plate. So normally we've been using plates about this big. These plates are going to be about this big. And you take that microbe and you streak it all over the plate in what's called a lawn. You're not going for isolated colonies. You actually take a swab and you dip it into liquid and you color nicely all over the plate and make the microbe grow all over the plate evenly in a lawn. And then you put on that lawn discs with antimicrobial drugs in it. So these are going to be like the ones we've used with bacitracin or opticin, but we're going to use 6 different discs. Some of them are these, some of them are different. So you make the lawn, you add your drug discs, you incubate, and then you measure the zones of inhibition. And some drugs won't give much of a zone. Some drugs will give a huge zone. But we're actually going to measure how big is the zone. And then we use a diagnostic table to determine whether that strain is resistant or intermediate or susceptible to the drug. We don't just look, is there a zone, but it has to be a certain size for a certain drug. And if you find for your bacterium that you used for this test that there were 3 drugs, let's say 4 drugs, these 4, the bacteria was susceptible or sensitive to the drug or killed by it, those 4 would be good candidates to give to the patient to help them cure their infection. That's the best way to find the right drug for the right situation, is to literally test it. But this takes time. The fastest you could do this is probably about 36 hours to accomplish all of it if you start right away. So tomorrow, what we're going to do is each person in the class is going to have a big plate, and you're going to have a tube of broth. that is either Pseudomonas aeruginosa or Staphylococcus aureus or Proteus vulgaris. Those are the three. And you're going to start your plate. So you'll dip a swab in the broth. You'll streak the plate a certain way. I'll show you tomorrow. And then you're going to put on 6 antibiotic discs, and we let those grow overnight. So tomorrow at lab time, we'll go in the lab. We'll do that. It'll take about half an hour. Then we incubate them overnight. And then on Wednesday, during lecture time, we'll measure the zones and determine which drug is going to be the most effective to treat that strain. It's fun. And there's one short like lab assignment worksheet to do on that. That'll be our last lab thing of this semester. That's how you determine what's going to be the best drug for this particular infection. And then once you know, okay, what is the right drug? What would be the best drug to use? Then we need to know how much should we use? What would be the right dosage or range of a particular drug? And that depends on this concept called minimum inhibitory concentration, or the MIC. How much of that drug do you need to actually treat the infection? And MIC values, people have determined those in a lab setting. So what they do is they make broth tubes with equivalent numbers of bacteria. You do a broth inoculation in a very standardized way. And what you change in the tube is how much of the drug. What's the drug concentration? So these numbers across the bottom here are telling us what is the drug concentration in that tube. And they've got it in micrograms per mil. And what you are looking for in this type of experiment is what is the concentration of drug that stops microbial growth? In this example, what seems to be the minimum inhibitory concentration that's stopping the growth? What's the right amount? Eight, it looks like the broth is still pretty clear. Whereas if you have 4, we'll just call it units. 4 units, you've got a lot of growth. 8 units, it looks like you don't have growth. So for this drug and this particular strain, whatever it is, the minimum inhibitory concentration for this would be 8 units, which is in this case microgram per mil. And that tells you, okay, in a test tube in the lab, how much does it take of the drug to stop microbial growth? Minimum inhibitory concentration. And this, like, people don't keep doing this over and over. It's kind of known from previous experiments what the MIC is, but this is how it would be done. This is showing, like, for multiple types of drugs, clindamycin or penicillin or erythromycin, what is the MIC? I'm going to use this slide to just put one concept, which is MIC values are specific for a specific combo of microbe plus drug. So for example, we could say that the minimum inhibitory concentration for clindamycin, I'm going to pretend that this is E. coli. So to use clindamycin to treat E. coli infection, you need more than 32 units. But to use penicillin to treat an E. coli infection, you would need 0.06 units. To use erythromycin to treat this infection, you would need 8 units. So it's not just specific for a drug or a bacterium, it's the combo of the two. Combo of the two is important. So looking at this, between clindamycin and penicillin and erythromycin, which one would you not want to use probably? And why? Which one would be the best to use? Yeah, I think penicillin would be the best to use. Why would it be the best to use?
After the fourth. Growth control.
So penicillin stops the growth with a low amount. All of these, well, clindamycin never stopped the growth actually, even with this amount. So it seems like this drug doesn't even work against, clindamycin doesn't work against this bacteria. So why prescribe it? But between these two, you could give a person a low number of units of penicillin and it would stop the growth. Or you could give them a medium number of units of erythromycin and it does stop the growth, but we would rather give people a low amount if we can. So this kind of also highlights something really important about MIC is that low MIC values are preferred. We kind of prefer to use drugs with a low minimum inhibitory concentration so that we can give patients minimal amount of the drug. That means they would have to take smaller pills, not have to maintain a super high concentration in their body. So we'd rather give them a small amount of drug that works well if we can. So we would prefer to have low MIC value. Low MIC means it just takes a little bit to actually kill all the microbes. And that's a good thing. The other reason that we prefer to use low amounts of drugs is because of toxicity issues. So you can pick out almost any substance on earth, and if you take enough of it or drink enough of it, it will kill you, even water. So we don't want to prescribe drugs that you have to take a huge amount of to have an effect. We want to use low amounts, and that relates to, I'll come back to this chart in a minute. therapeutic index. So we got two big values that we're concerned with when prescribing drugs. The first is MIC and the second one is called therapeutic index, or the TI. There's a lot going on this slide, and this is going to be the last like major slide we get to today. So therapeutic index has a very simple calculation, which is called the median toxic dose over the median effective dose. Don't write that down yet, but that's what therapeutic index is. And therapeutic index for our class, we are going to learn as this equation. So TI stands for therapeutic index. Equals toxic dose over the MIC. So MIC, we know what that is now. It's how much of the drug does it take to kill a microbe in a test tube? And they're calling that here the median effective dose. That's similar to the MIC. What we haven't looked at yet is what is the toxic dose. Toxic dose is going to be the amount of the drug that causes some kind of significant side effect to a person. And it could be death, it could be some level of harm below death, but something that's harming the person. Anything, any chemical in the world, there's a toxic dose. Alcohol, water, sugar. Too much sugar too fast. There's a toxic dose. So therapeutic index is kind of measuring, okay, what's the numerical relationship between how much does it take to hurt you, the toxic effect, versus how much does it take to help you? Another way that we could write this is how much of it does it take to harm you over how much does it take to help you? And we want those to be far apart. We want therapeutic index to be a big ratio. So it's a ratio. You're just dividing the harmful dose by the helpful dose. So here's an example. We're going to use ibuprofen as the example. When you guys take ibuprofen, how many pills do you take? 2 or 3? I take 2 if it's just some normal headache, and if I'm like really hurried, I'll take 3. And my younger kids take 1. They're actually gotten to 2 pill size by now, but they're so used to taking 1, they're like, I'll just have 1. Okay. So we're going to say the therapeutic effect for ibuprofen is 2 pills. 2 pills. Okay, so we're gonna make this next number up. How many ibuprofen pills would it take to seriously harm you if you took that number at once? Ballpark it. I think that's reasonable. Were you gonna say 10? I'm gonna write down 10 on the board. Don't go take 10 tomorrow, but we're making that up as the values. Okay, so 2 is gonna help you. If you're taking 10 or more, that's probably gonna hurt you. Don't take 10. What if we don't do this, but what if we were giving people selling a drug that 2 pills would help you and 4 pills would hurt you? That's really a more dangerous situation. It's too close together. Those two numbers are too close together, and that would give you a low therapeutic index. Like, yeah, it can help you, but you're approaching the range that's going to hurt you. And that's just not a safe situation. So we would rather have a high therapeutic index instead of a low therapeutic index. So if we filled those values in on this equation here, and this is made up, okay, so therapeutic index for ibuprofen would be, okay, it takes 10 to harm you and it takes 2 to help you. So we'd have 5. And that's a reasonable size number. But if it took 4 to hurt you and 2 to help you, therapeutic index is 2, that's too low. That's too close together. And you can think of it as like, how close is that to overdosing on the drug? You want those numbers to be very far apart. So you want a big therapeutic index. If we're going to give a person a drug, we want to give them a little bit that helps, not get close to the level that hurts them. Therapeutic index. So what I want to spend, I want to give an example these last 3 minutes of how you calculate therapeutic index. And we've got a chart here that's showing MIC values for certain pathogen in combination with certain drug. So these are MIC numbers. So we could look for, say, Staph aureus, penicillin, the MIC is 4. It would take 4 units to kill Staph aureus in a test tube. The MIC for ampicillin is 0.05. It takes way less. The MIC for sulfamethoxazole is 3. So example problem that I'll leave you with today is this. Calculate therapeutic index for S. aureus treated with penicillin G if the toxic dose is 5,000 units. So I'm using units instead of micrograms per mil. You just call it all units. We're not going to do conversions of units. We'll just call it units. And here's how you would set it up. PI equals toxic dose over the MIC, which is 4. I mean, 1250. 1250. That's a big number. There's no units on therapeutic index. It's just a ratio. It's just a number, and you want it to be a big number. So that's the type of math that's going to be on the final, and we'll do some more examples Wednesday. Tomorrow we'll be in the lab at the normal lab time. So I'll see you there.